Hello and welcome everyone to joining us today's 4 CPC of palliative care medicine. I assure you that this CPC will prove to be fruitful and informative for all the participants. And it's my pleasure to welcome all of you. Now the time has arrived to add some dignity and fragrance to our dice. It is the time to invite our honorable dignitaries to occupy their respective place here. Now, without further ado, I would like to welcome respected uh, Puneet Saxena sir on the dais. For establishment and growth of palliative care department is very inspiring for all of us. Thank you, ma'am. Now I hand over mic to Dr. Madhulata for further CPC continuation.
Good afternoon, everyone. So now let's commence this CPC without any further delay. So before we commence the CPC, let's understand the SOP of the procedure from the convener himself, Sir, Dr. Puneet Saxena, sir.
So good afternoon, everybody, and welcome all the senior faculty members and dear students. And this is the fourth episode of CPC in the current session, and I welcome you all once again. So as you all know that we've been doing CPCs on every third Thursday, barring few arrangements if there is any compulsion. So it's a very important academic parameter of the institute, and we like that there should be an active participation from all the departments. And those faculty members who are present here, please convey this to your fellows and your students that they should be present here in the maximum number, because the work which the department puts in to present a rare or difficult case is immense. And we all are benefited, especially the PG students, and it is disheartening for the department if there is less audience. So that is the another thing. And if the format, I think we all know by now that the first few minutes are given to the department to showcase their progress and the recent developments which they have undergone. And then you have a case which is basically involving the clinical aspect and the pathological and the radiological and the various other departments to evoke interest of the maximum number of the faculty departments, whichever is possible. So we are set again here for another interesting case presentation by Department of Palliative Medicine, which is a relatively new department, and I congratulate Dr. Ashwin Mathur the way she has developed and started the department, and she has got now postgraduate students for the first time. And being in the government setup, it's a rarity that only few medical colleges in India have a full-fledged this palliative care department. So without any delay, I will. The next CPC again will be done by the Department of Ophthalmology. So I don't know if there is anybody from ophthalmology present over here, but it is scheduled on 18th of January. That would be third Thursday, and the final dates and time is 1 o'clock. But because of the today CME organized by Dr. Bhandari here in the same complex, we had just shifted the time to 1:30. So it will be 1 p.m. on 18th of January. Department of Ophthalmology. So, Madhu, you can carry on.
Palliative care is about living life to the fullest and with dignity, even in the face of illness. As there is end to cure, but there is no end to care. The Department of Palliative Care was started in our institute in February 2020, and with great efforts, earnest efforts of Dr. Ashwin Mathur ma'am, and today, in a short span of 1.5 years, the department has grown by leaps and bounds. And to know further about this novice departments, let's welcome ma'am herself, Professor and Head of Department of Palliative Medicine, Dr. Ashwin Mathur.
So thank you, Madhu, and thank you, everybody. Thank you, Dr. Puneet boss. Most respected seniors here, I see Dr. D.S. Meena sir. We have Dr. Surajmal Verma sir with us, whom we will introduce after this CPC when Principal sir is with us. All seniors here, dear colleagues, dear friends, residents. At the outset, I would like to thank you all for coming for this CPC with all these other programs going on in our institution. And I must say that coming at the heels of CPCs by bigger established departments like pediatrics, medicine, and surgery, We take it as a grateful recognition of our department and our services. Thank you very much for joining us. So, in short, a very short review about what our department is. And for those who are not very aware, because you see, palliative medicine is a relatively unheard of branch in our part of the world. Although in the more developed countries, it is an established branch, it is doing well, and it is to be a very important it is a very important part in continuum of care. So, regarding what is palliative care? Palliative care is a care which deals with patients with chronic life-limiting illnesses. We focus majorly on the quality of life of the patient as well as the caregivers. We do this by a holistic approach in which we take care not just of the patient's physical aspect, the illness, but also of his social, emotional, cultural, psychological background. And we are one of the few people, or maybe the only ones, who put equal emphasis on the care and value addition for the caregivers. Regarding why it is required, so you see in WHO way back in 2014 passed a resolution saying that strengthening of palliative care services as a component of comprehensive care throughout the life course of an illness should be the goal of treatment. And it is also important because there is a very large unmet need for palliative care services. Worldwide, there are about 78 million people who require these services, and most of them live in less developed or developing countries. Only 14% of people have their palliative care needs met worldwide. And in India, if we see the data, it is almost just 1%, which is negligible. So palliative care is a major need for today. Why? Because with greater advances in medical science, we have more people living with chronic illnesses. There is a rising burden of non-communicable illnesses, and also some communicable illnesses or infections are on the rise. For example, lately we saw the COVID pandemic. So when should palliative care be started? Contrary to the belief that palliative care is an end-of-life care, ideally it should be started at diagnosis of an illness. So no doubt, earlier disease-directed treatment definitely takes a precedence, which is as it should be. But later on in the disease trajectory, when there is minimal disease-directed treatment or there is no disease-directed treatment left, palliative care takes on majorly. We take care of the patient in his end days, which we call as end-of-life care. And that is not just all. When the patient passes away, we are still with the family. We support the family during the bereavement period. So another question, who are the patients who require palliative care? So again, as is the general belief that palliative care is required only for patients with malignancies, data shows that palliative care is required in almost every chronic illness of every other system. For example, as you can see in this data, palliative care is required in long chronic illnesses of cardiovascular system, of hepatic system, of renal system, of neurology, of musculoskeletal illnesses, and even some infectious illnesses or communicable illnesses like HIV/AIDS or multi-drug resistant tuberculosis. And now we have a lot of patients who are living with COVID sequels. So who provides palliative care? So in our institution, the Department of Palliative Medicine does it. So as far as our journey is concerned, we started as a palliative care OPD in August 2014. And I'm happy to say that we have seamlessly converted it into a department in February 2020. We started our home-based care services in 2021. In 2021, we got NMC approval and we were given 2 postgraduate seats. So we now have 2 postgraduate students per year. So over the span of 3 years, we have 6 very hardworking and very dedicated residents with us. We have now a fully functional OPD, indoor patient department, daycare, home care services, and we are doing a lot of interventional pain management procedures. I would like to highlight a few firsts about our department. Our department was the first government medical college in the state to start a MD program. Our department was the fourth in the country to start a MD palliative program after All India Institute of Medical Sciences, New Delhi, Tata Memorial Hospital, and Gujarat Cancer Research Institute. Subsequently, now we have a lot of institutions who are now providing MD and DNB in palliative care. We were the fully first department in our institution who got fully digitalized through the IHMS software. So we have a department in which the OPD, the IPD, the daycare, everything is fully digitalized. We are the first in the country to practice non-cancer palliation. We have a registry of all palliative care patients. We have a registry of all patients on opioids. Our services in SMS, see, we started in 2020, but we do not have a very structured data about 2020. So all my data starts from 21, 22, and till November 23. So as you see, our OPD services in SMS are gradually on the rise. It is consistently on the rise. This is our OPD in SMS. If you want to visit, it is in Dhanvantri Bhavan on the 4th floor, room number 417. We started OPD in State Cancer Institute in August 21. And since then, over a span of 2 years plus, we have about 190 patients registered with us in State Cancer Institute. Our OPD, which started in late February this year, has benefited about 700 plus patients. Our home-based care services, we started in 2021. We have a total of 86 patients registered with us, but I must admit that due to some logistic challenges, we are doing this home care services only once a week because there is an NGO which supplies us mobility support. So they are free with their ambulance only on one day. So we usually do it on a Saturday, and we are currently limiting ourselves to only Jaipur jurisdiction. So again, as I said, we are practicing non-cancer palliations. About 40% of our patients registered do not have cancer. So we are a center. We practice non-cancer palliation. And we also want to reiterate the fact that palliative care is not just for cancer patients. Again, another slide which shows that from amongst the almost 18,000 patients registered with us, we have these many number of patients on opioids. So again, a humble request, please do not consider us as a pain center, and please do not consider us as just an opioid dispensing center. We have a lot of specialty clinics going on in our OPD. We have lymphedema clinic on Monday, a spine and joint clinic on Tuesday. Wednesdays are for psychological counseling and bereavement care. Wound management, stoma care clinic on a Thursday. Nutritional counseling on Friday and Saturdays. We have a very busy neuropathic pain clinic. We regularly undertake minimally invasive interventions. And as you can see here, almost 25% of our patients require some or the other form of intervention. Our equipment, armamentarium, through which we do all this, through which we give all these services, are a cooled RFA machine. We have a dedicated ultrasound machine for our department, an ozone generator, a PRP machine, lympha press, and TENS machines. We regularly and very regularly undertake patient awareness programs in which we generate awareness not just among the patients, but also on their caregivers. We have been in the print media a couple of times this year, but thankfully they were for good reasons. And after this, I must say the footfall in our department has increased substantially. During the Science of Life exhibition, our Honorable Health Minister showed deep interest in our department. He heard us at length and appreciated our work. We organized a Farooq Abdullah oration by Dr. Frank Ferris, who is an authority in palliative care himself. We were a very active participant in organizing a successful workshop on the role of social workers in palliative care during a national conference of Indian Academy of Palliative Care last year in Jaipur. We have organized and we continuously keep organizing quite a lot of CMEs to disseminate the awareness, the need, and our services for palliative care. During the Platinum Jubilee celebrations, we had the honor of having Dr. Rahul Rastogi with us, who is authority in interventional pain management, and he taught our department a lot of nitty-gritties about how to do interventional pain. We are a training center we are a government of Rajasthan's training center for training of palliative care in the state of Rajasthan. We have so far trained. Good afternoon, sir. So, like I was saying, we are recognized by the government of Rajasthan to be as a training center for palliative care. We have trained around 174 medical officers all over the state as yet, and more batches are in pipeline. They not only just get theoretical knowledge, but we give them hands-on training about palliative care services in our institution. In collaboration with the Indian Academy of Palliative Care, we organize a 6-week certificate program on the essentials of palliative care. We have done this training for 15 medical officers and nurses as of now. We have been able to organize an end-of-life nursing education consortium for nurses, in which we trained 40 nurses, and another batch is scheduled some early next year sometime. Regarding the research and academic activities in our department, we have a very tightly packed schedule of academic activities in our department. We have case presentations on Monday and Saturday. Tuesdays, we have lectures. Wednesday is reserved for a seminar. Thursdays for a journal club. And Fridays, we have a grand round. So as of today, we have 7 papers in this. Since we are a very young department, I must say we've been here just for around 3 years. In this span, we have published 7 papers in NMC-approved journals. 3 posters have been presented by our residents in national conferences of palliative care. There is a chapter by a faculty in a textbook on opioid administration. 7 projects are ongoing in our department after due approval of the project steering committee and ethics committee. We have completed 1 project on opioids in the multidisciplinary research unit of our institution. We regularly have interdepartmental classes. We are very active members of the tumor board. And we also take online pan-India classes for postgraduate students, MD and DNB residents of palliative care all over the department, all over the country. So, and lately a resident, a very dedicated resident, he's sitting here, Surendra Kumar Pingolia, he got a 2nd position in Delhi IAPCon. I'm happy to announce that our center, our institution has been re-accredited as European Society of Medical Oncology designated center for integrated oncology and palliative care services for 2024 to 26. So this is just an example of the online classes we take pan-India for PGs from all over the country. And not only just this, we just don't focus on the residents. We are very much interested in professional development ourselves, and our faculty undertakes regular such curriculums. This was a curriculum which was organized a few days back in Manipal. We have since our specialty requires an interdisciplinary team, we have a collaborative team of pediatricians, psychiatrists, physiotherapists, and nutritional experts. We have Dr. Ramesh Chaudhary with us, who has just joined, and he's a pediatric palliative care physician. We have a lot of NGOs who are partners with us. For example, one of them who has been associated with us since 2014 is Jeevdaya Foundation. And I must congratulate Jeevdaya Foundation from this podium. They have given us a seamless supply of oral morphine tablets since 2014, and they are carrying on till today. We have other NGOs with us like Yatanshil Parmarth Sansthan and Munshi Roopram Charitable Trust, who is a partner in the home care services. We have Jaipur Cancer Society and Sanjeevani people with us as social workers. Until we have a hospice of our own in some time later on, we utilize the services of Avedna Ashram and Santopa Dullabji as our hospice. The way forward, which we can think, we are always open to suggestions and guidance. We plan to make our institution the center of excellence for palliative care services. We already are practicing non-cancer palliation. We will take it forward. And we have now started our services even in acute illnesses. We will further expand our home care services as and when our logistics improve. We are already designated as a training center by Government of Rajasthan, and we will shortly be starting teleconsultation services for people in the remote areas of the state. So our journey continues. We are thankful for the guidance and the advice that we have always been showered upon with. And we request you for more guidance, more feedback, more wishes, so that we can live up to our philosophy of adding life to the ears of our patients. Thank you very much.
Now, before moving towards the case presentation, I would like to welcome our respected principal, sir, in CPC, 4 CPC of Palliative Care Department. Sir, your deeds have always inspired us to dream more, learn more, do more, and become more. Sir, you are really a true leader. Thank you, sir. We are lucky to have SMS alumni of batch 1954, ENT surgeon Dr. Suraj Verma among us. He has received many achievements and awards. International Award of Best Doctor of National Health Insurance Organization inspired. Imperial Government of Iran is one of them. He is also founder president of various societies. He is doing free selfless work to field of cancer awareness. He also has a keen interest in palliative care medicine. Thank you, Principal Sir. Thanks a lot of respected Dr. Suraj Verma Sir for being us in CPC presentation. Thank you so much, sir. Now, heading towards the CPC case presentation, I hand over mic to the Dr. Mathur.
Now let's begin to the interesting case that we have today by the Palliative Department. So I welcome Dr. Shri Harsh, who is second year resident from Palliative Department, to present the case.
Good afternoon, everybody. So we have our patient, he's 73-year-old ex-serviceman who is a resident of Jaipur, presented with chief complaints of pain, redness, and swelling in his right leg, ankle, and foot for last 2 months. On history of presenting illness, the patient was apparently normal before 2 months. Then he developed pain in the right lower limb involving his foot, ankle, and leg below the knee. He mentioned this sprain, which has happened 2 months back, which got resolved after 5 to 6 days, but the pain persists. The pain was insidious in onset, it was non-dermatomal distribution, it was globally involved, and the pain was continuous in nature, burning, tingling in character, and was associated with occasional shooting sensation also. The pain gradually increased from a pain score of NRS 3/10 to 9/10 at the time of presentation to our OPD. The pain was, when we saw the patient, the pain was so severe intensity that he was not allowing us to touch the affected area. The patient was not able to walk or take a step due to severe pain. The pain relief was inadequate with conventional analgesics, both oral and parenteral. And the patient now is in agony, shouting and anxious, and was in a low mood. And there was redness in the leg for past 2 months, which was insidious onset and continuous in character, and no aggravating or relieving factors. There was swelling, which gradually started at the foot, slowly progressed to the ankle up to the mid-calf. And there was no aggravating or relieving factors for that. And there was no history of any major trauma, no history of fracture, no history of joint pain, early morning stiffness, or rash anywhere in the body. There was no history of uveitis or pericontitis or any similar pain in the upper limb. And there was no history of hemoptysis or hematuria. There was no history suggesting of prolapsed herniated extruded intervertebral disc for the patient. And he is a non-case of hypertensive for past 32 years. And his blood pressure is under control with the medications. He's a non-case of peripheral vascular disease, and which was treated 4 years back, and is on oral medications. And there was a history of long-standing ulcer in the right foot 4 years ago, which has healed after the treatment of PVD. And he's a non-smoker for 42 years and stopped since 14 years. He used to smoke BD 2 bundles per day. and he's a non-alcoholic for past 60 years, and 150 ml of liquor he used to consume per day. And now he's a non-smoker and an occasional consumer of alcohol. And there was no similar history in the family. I invite Dr. Gaurav Sharma to take over this to discuss the past history of the patient.
So past treatment history is a little bit significant. Apparently, he was normal 4 years back. Then he develops pain in the lower limb up to the mid calf, as Shri already told, and he took analgesic for almost 2 years. Pain was dull, aching, and correct, and while walking, he was developing pain. So claudication symptom is there, which not fully removed. And 2 years back, he developed a non-hearing ulcer of that type. So he consulted for the management of this, and after thorough examination, he was advised venous and arterial Doppler for right lower limb and followed by CT angio. So I now invite radiology colleague Dr. Ankita.
So the color Doppler study of the right lower limb was done, which showed biphasic flow in the right external iliac and common femoral arteries, with absent flow in the popliteal, posterior and anterior tibial, as well as dorsalis pedis arteries. So peripheral vascular disease was suspected on this, and the CT angio was also performed for the patient, which showed partial filling defect in the right superficial femoral and popliteal arteries with approximately 50 to 60% stenosis, and this caused a decreased flow in the right anterior tibial, posterior tibial and peroneal arteries, and absent flow in the dorsalis pedis and plantar arteries. So these findings were suggestive of peripheral arteriocclusive disease with chronic thrombus in the right SFA and popliteal arteries. I now invite Dr. Anula Sisodia ma'am for further discussion.
On seeing the color Doppler and CT angio, the patient was advised to go surgical correction, and that was femoral popliteal bypass grafting. But as the patient was not willing for the open surgery at a department, he went to endovascular surgeons for stenting. So.
So after stenting, the patient was maintained on anticoagulants in the aspirin, clopidogrel, acetylene, and cilostazol. Ulcer healed, pain was relieved, and patient is continued to be asymptomatic for the next 1 year. Then patient comes after 1 year to again palliative OPD, which I've already discussed by the Sri in the last 2 months ago with the newly developed very severe pain. So Shri will explain the general physical finding.
So when we saw the patient was conscious oriented, and he was very apprehensive, anxious, and was in a low mood. He was a moderately built person. There was no pallor, icterus, clubbing or cyanosis, and no lymphadenopathy. The edema was present below the mid calf of the right leg, at the ankle and the foot, and there was mild edema in the left foot. Head-to-toe examination was normal except the redness, edema present in the right lower leg, ankle and foot, and mild edema in the left foot. And there was the heel wound scar on the right foot of the patient. And local examination of the bilateral lower limbs. On inspection, there was redness, swelling present in the right foot, ankle up to the mid calf, and there was heel wound scar on the right foot, and there was no sinuses or dilated veins. And on left side, it was normal except the mild swelling in the left foot. And on palpation, the right leg seemed to be warmer than the left side. There was marked tenderness present, and there was allodynia present and hyperalgesia present. And movement was restricted due to pain. The power was normal, and Homan sign was negative on the right side. On left side, it was normal and normal temperature, and normal movement was present, and the power was normal. And while examining the peripheral pulses of the patient, femoral and popliteal pulses, bilateral was normal. The patient did not allow us to palpate due to severe allodynia the patient was having, and the posterior tibial and dorsalis pedis was not able to palpate, and the left side it was normal on palpation. The vitals of the patient was normal, and other system examination was seemed to be normal. And based on the history, we can summarize that we have a 73-year-old male who is a non-smoker, non-hypertensive, and non-case of peripheral vascular disease of right lower limb, who came to us with the chief complaints of pain, redness, swelling in the right leg, ankle, and foot for past 2 months. On examination, there was allodynia and hyperalgesia and raised temperature in the affected side. So for the further workup, we send the blood investigation, and the CPC was normal. Total count was also normal. Coagulation profile was normal, and blood sugar was normal. So was the glycosylated hemoglobin. Liver function and kidney function was normal, and also total protein and albumin was in normal range. And for immunological profile, we sent the investigation, and the CCP-RA factor was negative, CRP was positive, and the other immunological profile was also normal. And for further workup, I invite Dr. Gaurav Sharma to take over this.
So this is a pain mapping of the area. Then we put a screening tool for the neuropathic pain. To diagnose the neuropathic pain, we use this pain detect, which is a validated tool. And this validated tool show the detailed history. And out of this, we got the score of 27 out of 31. So that indicates the patient is in severe neuropathic pain. Then the anxiety and depression scores also shows the high scores. Then sleep quality index is also assessed by the Pittsburgh Sleep Quality Index. It is also show the poor sleep quality. So for the further workup, we send the patient to the radiology department.
So the X-ray of the right leg with ankle joint was done, which did not show any evidence of fracture or any lyticosclerotic lesion within the bones with the normal soft tissue opacity. On the color Doppler also, there was a normal flow and triphasic pattern of waveform in the dorsalis pedis and right posterior tibial arteries. And also there was no evidence of any deep venous thrombosis on the venous Doppler. On CT angio, there was no evidence of any hemodynamically significant stenosis within the lower limb arteries with normal opacification and a good distal runoff. I now invite Dr. Anula Sisodia ma'am for further discussion.
As we can see that the color Doppler is normal and there is normal flow, and so there was no surgical intervention to be done from our side, and ask the palliative medicine to continue medical management. So we rule out the vascular cause for the pain.
So to sort out to rule out the other causes, we referred the patient to the neurological department. So I invite Dr. Vasudev to please comment on that.
Yeah, this patient was referred to us to look the cause or etiology for chronic pain that was persisting last 2 months. So we did the NCB and both all motor nerve and the sensory nerve that was found to be normal, and the other workup including diabetic workup that was also normal. So on the from our side, EMG NCB was normal, while in both lower limb motor and sensory nervous system examination was normal. This rule out the possibility of neuropathy. Diabetic and other autoimmune profile was also negative. So the other possibility of immune mediated neuropathy was also kept, but the immunology workup was also negative.
So now where are we? We have sort of the opinion for the neurological point of view, CTVS, radiological. So now we come to the differential diagnosis. So I invite all of you to just elicit the discussion. If anyone can suggest what are the disease which can we think about to make a proper diagnosis.
Peripheral pulses are normal.
Peripheral pulses was normal, but the affected area, due to the severe pain, patient is not allow us to dorsalis pedis and the posterior tibial. But Doppler is normal. Doppler flow is normal. So CT angio is normal. He was a previous case of that vascular ischemia due to the blockage, but now the patient is blood flow is normal, evidenced by CT angio also.
Stent is doing fine.
Yes, so stent is working fine. Superficial femoral artery.
It can be causalgia. Reflex inflammation is causalgia.
Yes, causalgia.
Maybe damage.
So causalgia is basically damage to the nerves, peripheral nerves. Yes, that's an interesting one.
Not picked up by LCD agent.
Yes, yes,
Because they are
yes.
small nerves.
Yes, yes, yes. So for the DD, first we have divided the DD into the 4 parts. First is the soft tissue injury that may lead to the due to trauma, tissue trauma, or infection. Thrombophlebitis, arthritis, infection, soft tissue damage, tenosynovitis, fasciitis, radiculopathy, and fracture. So we have worked out for there are some points which are in against thrombophlebitis, where neuropathic pain is against the diagnosis. Then arthritis, because it's not only the joint which is involved, soft tissue is also involved, and infection is ruled out by the normal counts and no fever, and the tenosynovial fracture is ruled out by the normal X-ray. So we have ruled out the soft tissue part injury. Then the DD second major categories is vascular. So that is the first and foremost. So Raynaud's, DVT are the most commonly things when we see such type of patient, and it has to be ruled out. So there is a Raynaud's, because the temperature and all these things, this is only a 2 months history. The DVT, Homan sign and color Doppler is not suggestive of that DVT, so that is ruled out. Lymphedema is there is also no inciting factor is there. Then cellulitis and vascular insufficiency has been ruled out by the investigation. So vascular cause is also being ruled out. Now comes the neurological neuropathies. There are different neuropathies which can present like this. One is diabetes. So patient is non-diabetic patient. Then small fiber neuropathy, we can rule out by the EMG NCV, and then entrapment syndrome and discogenic pain. So there is nothing in favor of these. So then another entity which can produce, that is a myofascial pain due to the repetitive stress trauma or some sports injury or something that can lead to. But there is myofascial is there is specific trigger or something that has to be there. So myofascial pain is also not present in like so much severe pain and neuropathic pain. So what we left, we have sought all the things. Now what is left us? So I just summarized till now that there is a pain, tenderness, redness, there is a temperature asymmetry, allodynia is very important, hyperalgesia is there, and severe neuropathic pain. So as our friend already suggests, we make the provisional diagnosis CRPS type 1. So this is on the base of history, and till now whatever we have done for the workup, we make the diagnosis CRPS type 1. What is CRPS? It is complex regional pain syndrome. Now the name is also being a very complex. So why it is so? इतना complex नाम रखने की जरूरत क्या पड़ गई? सीधा सा नाम रख लेते. So what is CRPS? Previously we known जो हमारी when we are doing our UG or PG, then that this nomenclature was RSD and causalgia, reflex sympathetic dystrophy and causalgia. Then why the name is being changed? Because reflex is not there. There is no evidence there is a reflex, and sympathetic, not all the patient has the involvement of the sympathetic nervous system. Because of this disease has been divided into two type of set of the diagnosis. One is sympathetic maintained pain, another is sympathetic independent pain. And dystrophy is only present in the later stage. It's not very common. That's why the nomenclature is being revised by the International Association of Study of Pain in 1994, and they reclassified, renominate this as a complex regional pain syndrome. So complex regional pain syndrome is a neuropathic pain syndrome where the key feature is pain, severe pain, and that is disproportionate to the degree of tissue injury. So what is the classical thing? There should be some, if there is a pain, there should be some tissue trauma. This is the classical teaching. But here, the tissue trauma and the level of pain experienced by the patient is not synchronized. The pain is just too much, and it persists beyond the usual expected time of the tissue healing. So, jo tissue healing ke liye, the time is needed, the pain is persisted beyond that. This is accompanied by the sensory, motor, and the autonomic abnormalities that may include allodynia, hyperalgesia, pseudomotor, and the vasomotor abnormality. And later stage, it may be trophic changes can be accompanied with this. So, just little bit of epidemiology. Incidence wise, it's a 5.5 and prevalence is 21 either per 1 lakh of the population. And it's more commonly female are affected with this disease, and the distribution is a peak around the middle age, 37 to 50 years, and prognosis is better in children. Genetic predisposition is also seen there with the HLA DQ1 antigen. And this is the next point is very important. There is antecedent triggering event is almost 100% of the cases. What is that antecedent triggering event? There might be something which can lead to the immobilization, which can lead to the patient decrease in routine activity. Just like in this patient, there is a sprain. We have seen a nursing staff which CRPS develop only after the vaccination. So this trivial trauma can lead to the complex regional pain syndrome. So we have to be very alert to when we want to see this, and the presence of the fracture. In upper limb, the Colles fracture, sir, is there. The Colles fracture is very common to develop. And in the rehab settings, the shoulder hand syndrome, there are many names around. In the literature, there are 50 names given in the books, which is synonymous with this CRPS. So that's why the nomenclature is being commonly done. So every branch, they are the different name. So classification wise, there are the two broad categories: CRPS type 1 and type 2. What is the biggest difference? The type 2 is direct nerve injury. It is due to the direct nerve injury, and type 1 is after a trivial injury or soft tissue injury or trauma. So other clinical signs symptoms are the same. Now pathophysiology, little bit. This is the major slide of this whole pathophysiology, because when we want to treat the patient, we should know what is the pathology, what is the pathophysiology, how the disease comes, because the treatment depends on the pathophysiology. So we all know how the any nociceptor comes from periphery. There are 4 parts in the pain pathway: peripheral nociceptor, first order neuron, second order neuron till thalamus, then thalamus to somatosensory pathway, and then comes the descending tracts. So receptor, afferent, if and then central processing, and then efferent. These full pathway has been affected in this disease. How? The sympathetic, because A delta and C are the pain carrying fibers. We all know these are the normal somatic system. Now in this disease, what has happened? B fiber are sympathetic fiber. The coupling of A delta with the B fibers happen there. That's why the sympathetic system is getting involved. Then it is not only that limited to the B fiber, then A alpha and A beta. What is the A alpha and A beta? It is the touch and proprioception and the pressure. So these non-nociceptive fiber are also becoming the nociception. So that's why this whole pathophysiology is being involved, and the patient develops the hyperalgesia, burning pain, and sensitization. So the system of the central system, that is also involved. So based on this, how to diagnose, they have proposed, this is the diagnostic criteria given by the ISP, and it is the latest given by the 2021. After 94, they have given into 2007, and they revised into 2021. So out of this, there are the 4 categories: sensory, vasomotor, pseudomotor, and motor. So patient, first, there are 4 points: A, B, C, and D. Patient should have the disproportionate pain related to the tissue injury, and they have at least 1 symptom in 3 categories and at least 1 sign in 2 more categories. So this is the diagnostic criteria, and it is the history and examination based diagnosis, which can be confirmed later on, which I will cover. Clinical feature wise, it is a 5 symptom complex: pain, autonomic dysfunction, edema, dystrophy, and movement disorders. These are the major crux how the patient present to you in the OPDs. The Bonica, the father of pain management, they have given the clinical course. Patient comes into the acute stage, then later on it may be dystrophic and atrophic stage around the year if the patient is not treated. So diagnostic test, what I have, there is no gold standard diagnostic test, no objective test. We can directly say this, you are the CRPS. You have to take a proper history, you have to take a vascular examination, you have to take a neurological examination, and it is a diagnosis of exclusion. So it is not the first diagnosis. It's never the first diagnosis. It is a diagnosis of exclusion. You can quantify the damage by these tests like quantitative sensory test and autonomic function test. These are majorly from the research purpose, not usually done in the clinical practice. But yes, you can do the sympathetic plexus block. That is to diagnose the patient whether it is maintained with the sympathetic system or that, as I already told, sympathetic independent pain. So management. After made the diagnosis, you can go for the management. Management involves the rehab people. It's a very important psychotherapy. It has started from the start. Then there is pharmacotherapy is a long list according to the vasomotor, pseudomotor, sensory, motor, all the things. You have to choose the drugs wisely. Then interventional treatment, it is an important part. Sympathetic nerve blocks to diagnose, differentiate between the sympathetic mediated and intermediate pain, then intravenous sympatholysis, then mixed somatic and sympathetic block, then surgical sympathectomy, which people already doing since long, then stimulation technique. This is the most advanced treatment, the spinal cord stimulator or peripheral nerve stimulator or deep brain stimulation. And then some resistant cases may be benefited with the epidural clonidine and intrathecal baclofen. So these are the options available. When the pharmacotherapy is not useful, then you can go for the next step. So sympathectomy in form of upper limb, you can go for the stellate ganglion, and for lower limb, it is the lumbar sympathetic plexus, which is the target organ. So what is the evidence? So evidence is 2B plus positive evidence in stimulate lumbar sympathetic and spinal cord stimulation. Sympatholysis with the regional block is not recommended. So now comes back to our case. So what is happening? So we are at that day, provisional diagnosis has been maintained. So we have to confirm the diagnosis, something less. So we have put this diagnostic criteria. This is showing CRPS type 1. We go for the patient went for the diagnostic intervention to confirm whether the pain is sympathetic mediated or not. So we went for diagnostic sympathetic plexus block under CIAM with the dye distribution. So we can see that because the area of involvement is foot, so we put a single needle technique at the L4 level, and after putting the local anesthetic preservative free, we got the immediate pain relief due to the local anesthetic involvement, and our diagnosis was confirmed that patient was CRPS type 1 and it is a sympathetic maintained pain. Now comes for the long-term relief, because local anesthetic has a very short-term relief. So we went for the therapeutic intervention, which is in form of neurolysis at the 3 level, L2, L3 and L4. So there is a 15 centimeter. We all know the sympathetic chain is lying on the anterolateral border of the vertebral body, L2, L3 and L4. So we have to target this sympathetic chain. Like surgery, we have to remove that sympathetic ganglia. Here, we are putting the solution to block that chain. So this is we used alcohol 80%, 3 ml at each level. You can see AP, oblique and the lateral view. And then we put a dye to delineate, and you can see in the lateralmost pictures, farmost picture, that there are 3 needles, and the dye distribution you can see in the below 195 number film. So this is how we confirm the location, and then we put the patient. So we got the result, very good result. So you can see the before and after. The right side, you can see all the tendons are very good visible. Patient becomes pain free, and we put the scores in then the score is from 27 it comes down to the 8. Anxiety and depression score becomes very good, and the sleep quality is also improved. So on discharge, patient score was NRS 3/10. Patient was comfortable. We have put him on the anti-neuropathic pain medicine, anxiety, depression already. So then we put a regular follow-up, 15 days, 1 month, and 2 months. Now it's almost 2 months. Patient is doing routine activity and play happily. So take-home message is, we have to be aware about the diagnosis. There is a suspicion has to be there whenever you are seeing these type of patients, and meticulous history and neurological and vascular examination is most essential, and you can make this diagnosis only by the exclusion. This is not the primary diagnosis. And diagnostic intervention in form of minimal invasive intervention under CIAM, they are the very useful technique to go ahead. So multidisciplinary department involvement is a must whenever you are dealing with such type of patients. So that's how I conclude. Thank you. Thank you. Now I would like to invite DS Meena sir, because this patient is sent by him, and we have seen a lot of patients from sir. Sir, just 2 words.
I must congratulate मैम Ashwin Mathur. मेरे को इनके वर्ड्स याद आ रहे हैं. जब मैं स्टूडेंट था तो मेरे से कहती है कि सर मेरे को तो एक टेबल और एक कुर्सी दे दो, दैट्स ऑल, और कुछ नहीं चाहिए, मेरे को जगह नहीं चाहिए, आप तो इतनी सी जगह दे दो, कोना ही दे दो. ये वर्ड्स आज तक भी मेरे गुजरे हैं, जो डिपार्टमेंट इतना बड़ा हो गया. और ये केस एक्चुअली था मेरे से रिलेटेड ही था, एंड उनको बार बार प्रॉब्लम हो रही थी. देन आई रिक्वेस्टेड मैम तो किसी सेट की मेरे पास भेजो आप. तो एक्सटेंसिव वर्क हुआ. द पेशेंट इज एब्सोल्युटली फाइन, इज वर्किंग वेरी वेल and is okay. So I must congratulate ma'am. And Gaurav also, we have a lot of brachial plexus patients with a severe agony. We often used to refer them, and the patient feels fine. So I think this is the very good department which is dealing with such sort of the problems. And end-stage disease patients, it's a very good department for that. I must congratulate you, ma'am. You are doing a wonderful work. Thank you.
Thanks to the palliative department for such a wonderful CPC and for creating awareness regarding CRPS. Now I request Dr. Monica Jain ma'am to take on to the dais for the certificate distribution. I now request the dignitaries present among us, our beloved principal and controller, sir, Dr. Rajeev Bagarhatta, sir, to take his seat on the dais.
I will request Dr. Surajmal sir to please kindly come up on dais. We are going to do some honors, so we want that you should be an integral part. I will request Dr. Ashwin Mathur also to please raise the dais, since this is the CPC which is being headed by you. So please come. I request Dr. D.S. Meena sir to please come on the dais, because this is a very proud moment for all of us. So I would like to share that SMS Medical College is actually doing a great job in terms of patient care, in terms of education, in terms of promoting research. So this year the best research paper award goes to two persons. One is from ENT, Dr. Pawan Singhal, can you please come up? And another one is from neurosurgery, Dr. Rajeev Bagarhatta. So to do the honors, I will request the dignitaries to felicitate Dr. Pawan Singhal. So he has got this award in the senior category. Another recipient and co-recipient is Dr. Rashim Kataria sir, and he is from neurosurgery. And his best research paper award is entitled as Prediction of the Functional and Radiological Outcome on the Basis of Independent Factors, with special emphasis on the use of 3D printed models in craniovertebral junction surgery. So very exhaustive topic. So congratulations, Dr. Rashim. So more pleasure to share. Now we should all feel very proud. Two of our residents, one from Department of Pharmacology and one. Now something more to share. Our undergraduates have done wonders. Batch 2018. So combined medical service AR1 rank goes to Kailash Agarwal. Batch 2018. What a proud moment for all of us. Please a big round of applause for undergraduates. So do you have Kailash Agarwal here? So okay, fine. Then what about Rohit Sahu? Rohit Sahu? AR2? Not there. Okay. Ayushi Bhargav, are you there? AR10. Congratulations, Ayushi. AR19. Naitik Kavadia. All India rank 22. Sakshi Sharma. Come up. Big round of applause. हमारे बच्चों ने इतना अच्छा किया. Very good. ये नैतिक. Sakshi Sharma. All India rank 30. Chaman Sharma. Chaman, congratulations. All India rank 55. Harsh Shukla. All India rank 67. Meenakshi Jaiswal. All India rank 86. Kunar Murjani. All India rank 100. Shubham Gupta. Okay. And the last but not the least, All India rank 150. Deepak Khandelwal. So congratulations to each one of you, and it was the wish of principal sir, I must admit that, our dedicated and visionary and considerate but very much determined principal, that this should be the essence of the CPC. It should end with honoring and the felicitation of teachers as well as students. So thank you very much sir. I will propose a vote of thanks quickly because we all are getting late also. Sir, I want to say something else. Sir.
It was wonderful to attend the CPC, and coming from a young department, I just didn't know that so much of work is being done. And in fact, when Dr. Gaurav asked what was the different diagnosis, I was at my bedside. I didn't know what was the diagnosis like, and I just didn't know what term is this. Having said that, it's also very important that they are not only diagnosing the problem, but they are also treating the problem, the therapeutics part of it. So very, I should say, they are bringing relief to so many patients who are at their, who are at the end of the road. I congratulate you, and अभी बताया सर ने कि she just asked for a chair and a stool there, but the demands will increase now.
So before we end, I'll just quickly propose a vote of thanks. My heartfelt gratitude and thanks to Dr. Ashwin for producing such a lovely case and with multidisciplinary approach. That is the essence of the CPC. We have to have a challenging case which is having a diagnostic dilemma, and a very good job done by entire team of this CPC of Palliative Medicine. Dr. Gaurav, you have done very good job in this workup, and in the simplified way you have explained well all the concept. Probably I was also not knowing about complex pain regional syndrome. Now I'm very wise about it. So my sincere congratulations to Dr. Ashwin Mathur again and again. What a department. In a very short span of time, you are being recognized all over. So congratulations, and my extreme thanks to all the audience who are sitting at this point round. There was a program there in CME also, symposium also going down. Still you took all the time and came here. My sincere thanks to Vivanji and Shashank for taking care and recording all this CPC proceeding. The last recording we didn't send to you because we were busy in PACES, and we should be very proud that we have conducted PACES exam training program successfully. So big round of applause for our chair, again to the principal sir, who has this brainchild. So it has been very successful, and we are ongoing, and we are having registration of other things also. So congratulations, principal sir. And thank you to all of each and everyone who has attended this. I am sure that this unique case has made us wise enough. Kailash here. One. All India rank 1. Congratulations, Kailash. Thank you all. Thank you all the organizers here also. Thank you. Yes.